Good evening everyone. Today we'll discuss the laparoscopic entry techniques, the abdominal entry, that is the umbilical entry techniques. We have a various needles. So basically the entry technique, you can use various needles, or you can go for direct Hasson open approach technique or direct trocar placement without prior insufflations. What is various needles? Various needle, it has a tip. What are the part of the various needle? This is the various needle. Various needle. What are the part? It is your, this is your tip, and this is your drum, and this is your channel. This is your drum, this is your tip, this is your channel for attaching syringe. Okay, so basically these are the structures of a varus needle. It has a two parts. The again the blunt, this is a blunt parts, this is your blunt, this is your blunt part, and this is your sharp parts. So blunt central tip, this is your blunt central tip of a trochus. Okay, the blunt central tip of a trochus, this is a blunt central tips, this is a blunt central tip of a trocar. Okay, and a sharp needle. So basically the teeth has two parts. The teeth has two parts. One is your blunt central tip for trocar insertions and the sharp needles. Okay, so this teeth has two parts. Okay, so mechanism of actions. What is the mechanism? Why these are the, and this is the hole for, what is the hole? This is the hole is used for gas, for hole for insufflations. Okay, so basically the varus needle, if you describe a varus needle, there will be a tip. This is a 5 questions. This is your tip, this is your drum, and this is your channel for attaching syringe. Again the tip has two parts. One is your blunt central tip of a trochus, and this is a hole for insufflations. This is the hole for insufflations, this is the hole, and the sharp needle part. Okay, so basically the mechanism of actions, when you push against your abdominal wall, that will create a resistance. Okay, what happens when you insert this insert this varus needle, insert the varus needle into the abdominal wall, pushing up against your abdominal wall, pushing against your abdominal wall will give resistance over the blunt central tip, give resistance blunt tip. Okay, so now what happened? The blunt tip will goes inside, and the sharp tip needle will pierces the abdomen. Okay, so basically the pushing, when you push the varus needle push against your abdominal wall, when push against your abdominal wall, the resistance will created over the abdominal blunt tip will goes inside. Now the blunt tip goes inside, and the sharp tip needle will come outside, and it will pierce the abdomen. When it will pierce, there will be a loss of resistance created. Then after that, when the loss of resistance is created, the blunt tip will be come out. Blunt tip comes out. Okay, so basically when the resistance is lost, there will be a chances of injury to your bowel, bladder, or momentum surrounding structures, the visceral organs, aorta, IBC. So basically the loss of resistance, when you get the loss of resistance, the blunt tip again comes out, and that will prevent your further damage. that will prevent further damage. So I'll discuss I'll discuss the varus needle. Basically, varus needle has a structural. This is a teeth, and it has a drums and channel for it is a teeth, drums and channel for attaching syringe. Again, this the pushing again the teeth has divided into two parts: blunt central teeth of a trochus, sharp needles, and there will be a hole for gas process. Then again the basic mechanism, when you varus needle push against your abdominal wall, there will be a resistance will created. The blunt tip will goes inside, and the sharp tip needle pierces the abdomen. When you get a loss of resistance, the blunt tip will again comes out. That will prevent your further damage to the bowel omentums and the greater vessels aorta and IVC. So basically, the use of varus needle is to establish a pneumoperitoneum, and the prerequisite establish pneumoperitoneum in laparoscopy, and sometimes you can aspirate peritoneal fluid from the peritoneal cavity. So basically, two use: one is your establish pneumoperitoneum, and second use is aspirating fluids from peritoneal cavity. Okay, so the prerequisite for a varus needle insertion, the patient has to be lies in flat. There should be a nasogastric tube insertion, so that the gastric stomach will be empty, and the small skin incision depending on the size of a trocar, whether you are giving a 10 mm or 5 mm, based on that your skin incision has to be decided. It has to be given at the base of the umbilicus, and the direction of the needle is towards the sacrum. In a thin patient, it should go towards the sacrum, and it should be go 90° in obese patients to avoid injury to the aorta. There should be a clicks that are at the facial plane and the peritoneal levels. Second click at the after entering the peritoneal cavity. Then the pressure against the needle, and the needle will be retracted. What are the site of insertions? Sites of insertions. First site is your umbilicus. Umbilicus is the most common site. Second one is your left subcostal, that is your palmar point. Third one is your median supra-umbilical port, that is called as Li Huang point. Fourth is, you can go by median suprapubic region, and fifth is your left iliac fossa. Sixth is your transcervical and transvaginal. 9 is your Jane's point. Okay, so basically these are the point of insertions. Why the umbilicus is more common? Reason for umbilicus is the most common. Abdominal wall, because you know at the level of umbilicus, abdominal wall is very thinnest, because the aponeurosis is ending at here, thinnest, and it is more cosmetic. Very, very important statement. One is thinnest wall at the level of umbilicus, and it is very cosmetic because already there will be opening. And reason for supraumbilical entry. Sometimes we are going for supraumbilical entry because you know any pathology that will cause a large pelvic pathology. In case of supraumbilical entry will be done. Supraumbilical entry, large pelvic pathology and extensive adhesions. First was your pelvic pathology and extensive adhesions. These are the conditions where you should go for a supraumbilical port insertions. Okay. your palmar point. What is the palmar point? Palmar point, alternative site of entry, because I told umbilicus is the most common site, because there will be a abdominal wall thinness at the umbilicus. It is more cosmetic. The reason for supraumbilical entry, if you go for a supraumbilical entry, if you suspect any large pelvic pathology and extensive adhesion in that case, and the alternate site will be palmar point. If umbilical port is unsuccessful or difficulty anticipated adhesion, if you anticipate adhesion from prior procedure also, that cases you go for a palmar point insertions or 9th intercostal space axial line needle grazing upper border of 10 ribs. So location is, the palmar point is 2 finger breadth, 2 finger breadth below your subcostal. You can see this is the subcostal margin, 2 finger breadth below your subcostal margin in your mid clavicular line. This is a palmar's point, mid clavicular line. So basically the use in case of previous vertical scar. The palmar's point is used in case of previous vertical scar. This is the mid clavicular line, 2 finger width below the subcostal margin in case of previous vertical fracture. Check for dilated stomach, enlarged spleen, enlarged lobe of liver. Okay. You can see this is the mid-clavicular line. This is the subcostal margin. 2 finger breadth is almost 3 cm. This is your palmar's point. Okay. Palmar's point in 3 centimeters or 2 finger breadth below the subcostal margin in the mid-clavicular lines. And this is your median supraumbilical sports, that is Li Huang point, that is third most common, median supraumbilical sport. This is your median supraumbilical port, that is Li Huang point. So these are the laparoscopy entry point. You should know basic things. This is the basic entry technique. I told just introductions. In the next class I will discuss